Good morning, everyone, and welcome. My name is Elijah Doriellen. I'm a junior here at Florida International University studying economics. I'm currently participating in the FIU Honors College Hamilton Scholars Program here in Washington, D.C., working on the National Wind Surge and Wave Testing Initiative. I'm also interning in federal government relations at Innovative Federal Strategies. And on behalf of Florida International University, it is my pleasure to welcome you to today's panel on artificial intelligence and the future of health. Today's discussion comes at a pivotal moment. At the federal level, there is a growing momentum to harness artificial intelligence to advance healthcare outcomes, particularly through recent executive actions focused on accelerating innovation in areas such as pediatric cancer research, early detection, and precision medicine. These efforts reflect a broader national priority, leveraging AI responsibility to improve lives, strengthen systems, and expand access to care. Florida International University is proud to be a part of that effort. FIU is both AI ready and AI first, leading in research, workforce development, and real-world application through advanced computing infrastructure and major new research and clinical facilities. FIU is accelerating the translation of AI into secure, explainable systems while preparing a workforce aligned with national priorities. FIU students are also actively engaged in this space through initiatives such as our AI-focused fly-in here in Washington, D.C. Students are contributing to a conversation around innovation, policy, and the responsible implementation of emerging technologies. We are honored to convene leaders from government, academia, and industry for today's conversation on how cross-sector collaboration will shape the future of health. And now it is my distinct honor and privilege to introduce our president of Florida International University, President Jeanette Nunez.
All right, good morning. How's everyone doing? Excellent. Well, it's a privilege to welcome you all to our FIU in DC office. Thank you for being here. By show of hands, where are our students? As you can see, well represented. Thank you. Yes. And so to be able to convene our students with an extraordinary group of leaders, of course, faculty, federal policymakers, healthcare innovators, industry partners, today we come together around a topic that is not only defining the future of healthcare, but is obviously transforming lives. It's transforming how we understand, how we treat, how we diagnose, how we prevent disease. So for me, it's really exciting to be able to listen to this very important topic because we know that we're at a pivotal moment in medicine and in public health. And we have many individuals on behalf of the administration that are here that are focused on transforming healthcare. I want to recognize, of course, our Dean of the College of Medicine, our Provost, the entire administration, and our Board of Trustees. We're privileged to have so many of our trustees here with us today. We have our Chairman, Carlos Duarte, our Vice Chair, Alan Gonzalez. Then we have Trustee Peraza, Trustee Casanova, Trustee Leveña. Who am I missing? We're missing a few that might have stayed upstairs. Trustee Heisel, where is he? He's upstairs. And Trustee Popak, and a few others that have been with us the last 48 hours. But as we know, here this topic is something that our students are particularly interested in. That's why they're participating in this AI fly-in. Artificial intelligence is rapidly reshaping healthcare from earlier and more accurate diagnoses to accelerating drug discovery and to enabling more personalized care, precision medicine. We've seen those results up close and personal at FIU through the work of our very own Dr. Diana Azam, and you'll hear from her today. She's a researcher at the Robert Semple College of Public Health and Social Work, and I can tell you it's fascinating the things that FIU is involved in from a research perspective. I will tell you we are a top 50 public research university, Carnegie R1 Research University. We are doing amazing work. So for those of you that perhaps aren't as familiar with the work that we're doing, I know today's panel will provide you with some great insights to the impactful and innovative transforming lives, all the things that we're doing from a research perspective. They're using AI to test more than 120 FDA-approved drugs directly on living tumor cells to allow for that tailoring of treatment specific to the patient. faster than ever, more effective than ever. But with this opportunity provided by technology also comes responsibility. And that's something that I think we grapple with, of course, in higher education more generally, but making sure that AI that's embedded is ethical, that is accurate, that is the things that we're doing to provide security and the things that we know we're going to have to grapple with for some time. So at FIU, as we approach AI in health and biomedical research, we're doing so with intention. Just a few weeks ago, I was able to host an inaugural Horizon Summit in Miami. We brought together university and industry leaders to really talk about the future. How are we going to prepare? How is the university going to prepare for the benefit of our students? And one thing is clear, and I think everyone in this room will agree, that AI is not just the future. It's here, it's now, and we have to be at the forefront of that. And so that means, of course, for our students that we're not just AI ready, but that we're AI first. AI, not just literacy, but fluency. And so whether you're studying medicine or public health, engineering, or data science, we want you to be able to apply these tools to solve real problems, like improving healthcare outcomes and strengthening public health throughout our communities. The future of healthcare will be built at the intersection of science, technology, policy, and of course, the most important thing, which is patient-centered care. So that's why partnerships between the university and government, health systems, and industry leaders are essential. So these partnerships will ensure that innovation translates into real impact for our patients. And so that is part of our strategic plan. That's part of our pillars, making sure that student success, research excellence, and strategic alliances with industry will always be at the forefront of everything we do. So thank you all for being here. It's a privilege to be able to welcome you to our home away from home, FIU in DC, and looking forward to today's conversation.
Thank you so much, President Nunez. And please join me in welcoming Dr. Diana Azam, Associate Professor at Florida International University. Dr. Azam is with the Stemple College of Public Health and is a leader in biochemistry and molecular biology, specializing in precision medicine approaches to improve cancer treatments for both adult and pediatric patients. Her work integrates genomic profiling and machine learning to develop individualized therapies and address disparities in cancer care. Everyone, please welcome Dr. Diana Azam.
Good morning, everybody. Thank you all for being here for this important discussion with artificial intelligence and the future of healthcare. I would like to apologize first that I could not join you in person as I'm presenting at a conference in San Diego, but I do want to thank Carlos Becerra and Abby and the entire team for allowing me to join and participate virtually. So we are at an important moment where artificial intelligence is really starting to move from exciting ideas to impact patient care. In our work, we're using artificial intelligence to integrate it with functional precision medicine approaches to provide personalized treatment options for cancer patients that have exhausted standard of care, especially children with hard to treat cancers. I'm going to share my screen quick. 1 second. So I want to start by giving you an overview of what functional precision medicine is. It's really we take a small sample of the patient's tumor, we culture those cells outside the body, and then we expose them to hundreds of FDA-approved drugs, just like President Nunez just mentioned. These drugs include cancer and non-cancer drugs. And then within a few days, we observe which drugs kill the cancer cells, which don't. It's fast. And it creates a personalized treatment plan tailored to that individual patient. So we are now using artificial intelligence to make sense of this complex biological data that we generate. AI will help us recognize patterns in how different tumors may respond to different drugs. So as you can see here, it's a very complex system where we take the DNA, the RNA, and then the response to hundreds of drugs, all of that data, put it into a machine learning approach, and then that will enable us to better classify patients based on who is most likely to respond to certain treatments or not. Think about it. As we generate more and more of this unique data set, we'll one day be able to predict what works for each patient, hopefully without even needing a biopsy. So an example of this is, we have patients, this is a girl with metastatic osteosarcoma, a very aggressive cancer in the bone that responded to a combination of idarubicin and montelukast, which is an allergy medication. And so the question is, why did this patient respond to an allergy medication? And can we find biomarkers that will allow us to classify patients in the future that will respond to allergy medications? And we do that by taking all this data. As I said, it's a very complex data set where we start looking at what biomarkers will allow us to classify patients based on their drug response. For example, we have patients that respond to fenbendazole. This is an antiparasitic. So what targets or what biomarkers can we find that will allow us to classify patients that respond to fenbendazole? So ultimately, this approach helps clinicians make more personalized, timely, and informed treatment decisions with the goal of improving outcomes and reducing ineffective treatments. I do want to end by thanking the FIU leadership, President Nunez, Provost Behar, and Chair Carlos Duarte for really their incredible support of this work. Thank you all. I'm excited to participate today with you all.
Thank you, Dr. Azam. Now I'm pleased to introduce Mr. Dave Clark, policy editor at Punchbowl News. Dave covers Washington with a focus on Capitol Hill and brings extensive experience from the Washington Post, where he serves as the editor of the 202 newsletter, Congress editor, and White House editor. He also worked at Politico and Reuters, making him a leading voice in political journalism. Everyone, please help me in welcoming Mr. Dave Clark.
Kind of sounds like I can't hold a job, man. All right, we're going to have a great panel here today. Thanks so much, everyone, for coming. It's great to see so many students. So let me introduce the panel. We'll get going. Adam Aiton from Verily Health. Sunita Krishnan from the National Academy of Medicine. And Sylvia Gale from the National Cancer Institute. To start off, I thought each of you could just give a little brief overview of the work you're focused on and how it relates to our discussion today.
Great. Hi. Good morning, everybody. So whenever there's these DC fly-ins, it's that time of the season, that and 8th grade field trips to DC. So there's tons of buses around the city, and there's always that cycle. But welcoming everyone. I got one of these fly-ins actually next week as well. But so I'm the head of government affairs and public policy at Verily. For the last decade, Verily has been operating as an independent bet within Alphabet. Just last week, we reached a significant milestone of transitioning into Verily Health and being able to be an independent entity within Alphabet. So, there was a really important milestone for us to reach. We are still tackling the same sets of problems, ultimately looking at the hardest of the hard in healthcare and bringing precision health to everyone, everywhere. We do that through a diverse product portfolio, but really the underlying connecting theme is bridging clinical care and clinical research through AI and agentic forms of autonomous thinking with the ability to really improve care and outcomes. So, one of the milestones actually as well that we entered the market last year with a consumer app called Verily Me. If free to download, free to try, but if you think having your record all in one place, being able to query that record and empower you in order to make decisions as part of your care journey, give it a try. But underlying that, the core critical thing that we do at Verily is data curation. From our perspective, AI is not lacking algorithms. It's not lacking the ability to, come up with these ideas to have sophisticated analysis. It's about data. We got to harmonize, ingest, curate, and link data in order for it to be AI ready. And being able to do that at scale is going to be the important piece moving forward for us.
Good morning, everyone. My name is Sunitha Krishnan. It's great to be here with you all today. I am a senior program officer at the National Academy of Medicine, which is a part of the National Academy of Sciences, Engineering, and Medicine. And we were chartered by Abraham Lincoln, so we are a pretty old institution. And most of what we do across the academies is really look at evidence-based research and science, engineering, and medicine. So at least for my own portfolio, for the Leadership Consortium, which is the program that I work on, our main North Star is a learning health system. So I might repeat that a couple of times during this panel, but we really are trying to devote our time and energy to building a system that is consistently learning and improving. And a part of that right now is science and informatics. And so a lot of that work is around data sets and AI and how do we really try to improve these aspects of this overarching data architecture and infrastructure to improve the healthcare system. So that's a very high level of what I do.
Hello, everyone. Sylvia Gale. I am a scientific program director at the National Cancer Institute, which is the largest institute in the National Institute of Health. And we're under HHS, Department of Health and Human Services. So my role at the NCI, I serve as a scientific program director for bioinformatics and computational sciences. And I also coordinate all of the AI-focused research that we have going on at the NCI. I'm sure you can imagine, right, like with the NCI, we have divisions, offices, centers, and all of those groups are doing their own AI research, right? And yes, it's been approved through leadership, but like my role is just kind of to have a comprehensive view of what research we're doing. And I'll just say with AI, we're using AI from productivity. So we have our basic researchers who previously, after treating with cells with a drug, were counting, now we're using AI for that. In clinical realm, we previously had the clinicians trying to figure out, for trials, matching patients, now we have AI algorithms that can do that. And even in the administrative realm, with our grants, we have algorithms that we're using that are actually in development for helping us better to determine, to rate the grants, better to classify, just the different categories that, should be funded. So we just have a lot of exciting things going on in the AI realm right now. Glad to be here.
All right. We're going to talk for about 20 minutes, and then we'll open it up for about 10 minutes of questions. I'll start with one question. I'll just go to all three of you, and then we'll try to focus it on a little bit more of the areas you said you'd like to focus on. So first of all, where are we seeing the most breakthroughs or the most progress in AI and healthcare and medical research, and where should people maybe temper their expectations a little bit about how much it's going to play a role in the near future? Adam?
So I think the comments that you've heard this morning already indicate where the puck is going, so to speak. There's been the molecular profiling, discovery is obviously an opportunity that we've been seeing with as well as at NIH. The burden that's being relieved in terms of the workflows, the administrative burden, I should say. But, ultimately where we're starting to move towards is kind of higher risk uses of AI. Right now it's lower risk, and there's a lot to sort out in order to get to this next phase of where AI is going. You need to have regulatory frameworks in place. You have to have clear rules of the road. I don't know if folks saw the other week, I think the Meta had their metaverse, their virtual reality universe that was essentially closing down. One might think it could have been due to a lack of rules of the road. And so it's going to be really important for scaling up the use of AI to have those regulatory frameworks in place. We've had a lot of progress being made at FDA, at NIH, and CMS. Of course, getting something approved and cleared that's safe and effective only matters if it's in the market and being paid for. So having the structured partnerships between FDA and CMS for perhaps shared evidentiary requirements for approval to payment would be a really important place to start in order to build this framework.
Yeah, just to add to what Adam was saying, I think, obviously Dr. Assam had a great presentation before us about precision medicine and genomics and research. And so I think there's a lot of potential and exponential work being done in those arenas. I think that I just want to focus maybe on where I see the next phase of priorities occurring. And I think that's around clinician education and training to make sure that we are actually relieving administrative burden. And I also would say patient safety and quality. I think that this is a really great opportunity for us to take a look at some of the harms that still occur to patients in hospitals and health systems and say we have a chance now to really rework some of these quality metrics and safety metrics and use AI tools to make sure that we're actually giving patients a high quality experience. So I see that kind of happening in the next year or two, where if we really don't handle that right now, I think we're going to miss the window of opportunity there.
Sylvia?
Thank you. So I would say definitely, NCI, one of the areas we've seen is AI for clinical diagnosis. And just an example I'd like to highlight is some of our AI for MRI within the liver imaging and reporting and data system, or LIRADS. And so LIRADS is just a very systematic approach that allows for the categorization of patients with hepatitis B or C who had risk of developing liver cancer. I'm a little nervous. But so normally, this framework is very, very complicated. It's time intensive, and really there is also inter-reader variability. So then, there's an issue with reproducibility at times. And so at the NCI, what we focus on is trying to increase reproducibility by having an algorithm that's looking at a multimodal analysis. So it's looking at the wholesale, it's looking at pathology, it's looking at the lab work, it's looking at unstructured clinical data. So we're using all of this data now instead of, just the one liver image. We're using all of that data to kind of come up with a process, to come up with an algorithm that does say, hey, these are the patients that are at risk of developing hepatocellular carcinoma. And so we've had success. Liver cancer there. We've broadened that to prostate cancer. And we're actually now looking across to other cancers. So, this all sounds great and there's a lot of excitement, right? But one area where we really kind of have to temper our expectations, right, is this whole, AI is not going to come in and solve all the problems and have an end-to-end solution. We still need that human in the loop validating. We still need that human in the loop doing the quality check for AI. So definitely I would say that that's something that we need to keep in mind, is that we definitely still, while we're making all this progress, still need that human in the loop just validating.
Great. Sylvia, we'll stay with you.
Yes.
We're here in Washington, which is worse weather than Miami, as a few of you have told me. But there are some federal efforts here with regard to AI in healthcare. Maybe you talk a little bit about what role they're playing now. There's the executive order on pediatric cancer and AI. Maybe you just tell us a little bit about how that's going. And then Adam, maybe after that you could talk. You talked about rules of the road. Maybe you could talk a little bit about what you're looking for next and what role government has there. Sylvia.
That's a great question. So pediatric cancers are still actually very rare cancers. Only 1% to 3% of cancers diagnosed each year are pediatric. So the data is hard to come by, and the treatments is harder, right, because there's such little data. And so we've had since 2020 the Childhood Cancer Data Initiative. So that actually is a $50 million a year federal investment in researching pediatric cancers. And so through CCDI, since 2020, we have now put together a pediatric cancer data resource. And so this data resource includes whole slide images, proteomic, genomic, just all this different data on over 8,000 children with cancer. And what we're going to do now, keeping in mind that pediatric cancer and AI executive order, is now say, hey, we have all this data. So now what we'd like to do is kind of have a push to build infrastructure so that the broader research community that has been building AI tools, they have the tools. So now we want them to be able to bring those tools to this data. And we will actually, within the next few weeks, we're releasing a few highlighted topics. So highlighted topics are just a way for us to communicate with the public what our research focus are, and then we're inviting the public to submit research proposals in those areas. So we have all this data, and we're building the infrastructure for the research community to bring their AI tools to that data. And so we're really looking forward to see what kind of innovations will be proposed. It'll be very broad, from EHR extraction to just, basically, whatever people have to propose. We're here ready to listen with the data, and I'm ready to work together.
Great, thanks. And Adam, you mentioned rules of the road, which is an issue for AI in almost all its applications, especially here in Washington. What should the government do? But with regard to healthcare, what are sort of the big issues you're following, or you think people here should keep an eye on as far as where that debate may come up next?
Yeah, thanks. So I don't know if folks had caught an update from CMS, update to payment policy, and Dr. Oz had a really fun kind of one-liner in the press release. It was related to updating information technology systems, and the press release was something along the lines of, hey, the 80s called, they want their fax machines back. And unfortunately, that's exactly how information is still getting transmitted in health systems, despite the fact that we're talking about this really innovative stuff with AI. So kind of ground and temper, expectations, as we were talking about earlier. But there is a lot of progress that is being made. And one of the pilots I would like to highlight is the CMS Access program, which is really one of the first predictable pathways for digital health payment, where it's focused on prevention and wellness, but the idea is it's all through digital health and AI opportunities to meet outcomes. And there's 4 clinical tracks that they are testing out. The program's going to go live in June. But it provides the blueprint for how to get these products into the market, how to engage with Medicare beneficiaries in this case, and ultimately how to reach outcomes, because that's what we're trying to get. We're trying to get to outcomes, not more activity. And what's really unique about this particular pilot is that it's actually connected with the FDA. And there is a FDA Tempo pilot where, in order to get the agentic AI into the market that is supporting the Access program, they are taking applications, reviewing them, and allowing for your product to be in the market. As it's working, you're capturing real-world data, developing real-world evidence as part of an FDA submission. So this is the hand-in-glove approach that I think industry and stakeholders writ large have been wanting to see, with the FDA and CMS coming together to find ways to get products into the market faster, still with kind of guardrails and safety and effectiveness in mind.
Great. There's nothing I like more than getting a message from my kid's pediatrician saying, could you fax that over? I have no idea what they're talking about. All right, Sunita, we'll go to you. Obviously, medical advancements benefit everybody, but how do we ensure that the advancements that come out of AI and healthcare and research benefit all populations, not just well-off, people who are well-off? How do we make sure everybody benefits from this?
Yeah, I think that's a great question. And this loops back to maybe the endpoint of Adam's remarks, that we really need industry collaboration to make this work. Obviously, there are a lot of well-resourced health systems, and they already are deploying AI tools to their patients and also within their own EHR system. But then we're not thinking about those rural clinics. We're not thinking about community hospitals. Community hospitals are just trying to stay open. They don't have the resources to get a license for their clinicians to use AI tools. And when you're also thinking about rural healthcare, there are people that still don't have access to broadband. And so how can you assume they have a smartphone? So the digital divide is already widening with AI, I think, because frankly, we should have thought about this 3 years ago, and we didn't. And so now I think we're playing catch up because you already have a lot of large and medium health systems already moving on, and the race is already widening. So I think right now what's really important is industry collaboration, because I think for the people that are making these AI tools and also for EHR companies, I mean, I'm going to call out Epic here as well. I think it's really important that there is access to these tools, or there's a partnership where we are bringing in smaller health systems, we're bringing in more rural populations, rural communities to say, this is how you use these tools. Well, this is how you can get a license from us. And so I think until we think about the payment plan for this, and if we think about, how we're profiting off of these AI tools, we're not going to be able to actually provide access. So industry collaboration, I think we should have cheaper AI tools that people can actually afford. And then I also think we still need to think about the basic digital health disparities that we are still dealing with, and AI will not be able to fix.
Yeah, there's always a lot of talk in Congress about what to do with rural hospitals and how to get the money, but since it's Congress, not always a lot of progress. We will, that's my commentary, no one else's. Let's stay with you, Sunita. One of the other big issues is, when we're talking about this type of research and progress, is bias and making sure there's trust in the system. What are the sort of the best practices, or what's the best way of overseeing the development of AI in healthcare to make sure that there aren't biases in the system that could negatively impact patients?
Yeah, so I think one thing at least that we're trying to do more at the National Academy of Medicine is we've been creating a consortia of clinicians and patients. And so if patients and clinicians are not at the table when these tools are being created and developed, we're going to have another EHR disaster where EHRs actually caused poor quality of life and work for clinicians. And so I think right now we're really trying to prevent that and say, if I'm a patient, and we all are patients, and I don't know how many people have how many patient apps or portals on your phone. Maybe your health records are in like 3 different portals, and you're trying 17, there you go. So you're trying to juggle all of that. And so I think right now it's going to be really important that the patient is sitting at the table to say, I have 17 different portals and I can't figure out how to access all my records. If an AI tool was given to me, what would that do? But I want to work with you to say, this one AI tool can help consolidate my 17 portals, all my health records, and then I can actually understand what my care looks like and the care that I need. So I think when it comes to bias and trust, we really need to work with patients and clinicians at the table to say, as an AI developer, to say, this is what you need and I want to work with you. So I think that that's one part of it. I also think that when it comes to bias, if there isn't trust in the tool, then you can't necessarily solve bias. And I think for us, a big indicator of that is just working on creating a trust framework and trustworthiness to say, if I'm a user of this, how can I assume that what it's telling me is true? And also, how do I trust the information? And then how do I not put my own biases on it? And you can only do that through education and training too. So I think there's a lot of components here. I think that from a health system perspective, I would want to make sure that I train my staff and my clinicians to say, this is how you use these tools. This is how you prevent bias confirmation. And then as a patient, I would also want to say, let's work together to say, what do you need? Does this actually solve, some of the issues that you're facing with your own health, your own journey into the healthcare system? So I think there's a couple of little things here, and we can elaborate on that, but I'd open to other ideas too.
Yeah, I think that's the patient part there is very interesting. I hadn't thought about that as much. Like, you obviously, to build trust, you're going to have to sort of educate people that this is, why we're using that. You care to comment, Adam?
No, I agree with all of those comments. Fantastic. And another important piece to the puzzle too is going to be liability. So I've had some conversations with AMA, American Medical Association, and they're in the middle of tackling what this means for their constituency as well, making sure that there's a human in the loop, what is kind of AI stamped versus what's being done by humans, really important there. But ultimately, and I think there was just a report that came out the other week, the liability issue is a hang-up right now, and especially if you've got 50 different states doing with their state medical boards having kind of different ideas and policies in mind, it's very fragmented. So again, last week, as you can see, the theme here is lots of things going on in D.C. We had legislation that came out, not legislation, but a legislative agenda from the White House on preemptive AI. So again, getting away from fragmented AI policy across the states and having one unified federal policy.
Yeah, I agree with what both of you have said, and would just like to take a step back a little bit, right, and go back, right, to that tool, right, and just, keeping in mind, right, that the bias comes from several sources. So if the data that the tools are being trained on is not representative of the entire population, then the tools themselves can be biased and maybe will not work as well for some populations as well as they do others. And then also how we're maybe asking the questions, right? And you touched on that a little bit. So also, depending on how you ask the question, it could be a leading question and your output also be biased. And so definitely I would say a big thing to, focus on is just to make sure that data that we're using at the very beginning is representative so that, it can not be biased and be able to help all of the different populations.
Is there an issue in getting that data? Like, is it all readily available? Is it?
So I would say that there definitely is an issue with getting all of that data. And there are lots of reasons, right, why it is complicated to get representative data sets. And at the National Cancer Institute, and NIH, we have been working to just work with different populations. We have different programs such as All of Us, which are, kind of going into communities to help build that trust to say, hey, we're developing these tools, right? We have what we call cancer digital twins, and those digital twins are supposed to be able to computationally be able to predict a treatment outcome for a patient. And we're kind of going out and saying, hey, like if we don't have your information, if that's not part of how we're training this tool, then we don't have a digital twin that will work for you. So I think there are certain communities that have had a mistrust in giving their data and, for valid reasons, but now we're getting to the point where we have to educate people and say, if we don't have, data on you, then we cannot help you as well. So definitely we have those outreaches going on. So they'll go to barbershops, they're going to churches, they're just going around. And also I want to quickly touch on the Childhood Cancer Data Initiative. So that's another initiative that we have that is going into rural areas. So normally for there to be data that's initiation and part in a clinical trial, right? You're part of the Children's Oncology Group. And so we've been going through rural areas, just different groups that, maybe their physician isn't part of the Children's Oncology Group, and so their patient, cannot participate in this clinical trial and give data. So, those type of outreaches are important, and they're just some of the efforts that are going on in order to try to get data so that all of our AI tools that we're developing are able to benefit the whole country.
Can I just say one point? A week ago, we actually published a paper around building a digital and data architecture model. And I think that, it's a lot of what we've already been trying to do with a lot of different smaller data sets and other public and private data sets. But the whole point of the architecture is that, again, AI can't fix a broken data system and AI can't fix interoperability when literally, if those channels are not created right now, what is AI going to do? And so I think people kind of look at AI as a quick fix for data, but that is completely far from the truth. I think we need to focus on data and fixing the infrastructure and creating an architecture model that is almost like we're kind of using the term health data utility, which has a lot of different definitions depending on like what perspective you come from, since a lot of states already have HDUs. But if you, just like electricity, we all pay our electric bills, we all opt into electricity. If we were to do something like that with the health data utility model, where you're opting in as a health system to say, okay, all of our records can go into this model, then we would actually be able to have a more functional basis for actually understanding what all the data looks like across all the health systems in the country, which is step one. And step two, obviously, which you have to do in the same time, is working with the patients to say, this is how your data is going to be used. This is where it's going, so that we can build consent and trust. Because right now, I'm sure, again, I can also speak for myself. I don't know where my data is. I just, you scroll through the terms of agreements, let me just get to finish checking into this appointment, right? You're not paying attention because they make it very complicated. And so if we can try to reduce and create less of a burden for people to sign up for consent and know where their data is going, then that's part of the equation as well.
You want to weigh in, Adam?
Yeah, data, I could go on for a while. I know we don't have a while. So I first, the foot stomp, the portals, again, There's lots of opportunities out there to do that and consolidate. Verily me, not to toot our own horn too much, but again, that is exactly the problem that we're trying to solve, and being able to do it in a way that's user friendly, and being able to navigate that information that you have there in one longitudinal record, because ultimately at the end of the day it comes down to data. You had mentioned, Gail, the All of Us program. So again, not to toot our horn, but we run the All of Us program through our Verily Workbench solution, having a secure environment for collaborators to come together, share their data, and perform analyses. And that's exactly where the future is heading. When we say multimodal data, it's a very aspirational goal, but still at the end of the day, what are we talking about in terms of what that data means? It's the quality of the data. You can't have dirty data come in and all of a sudden it becomes good data that you can be making actionable decisions on. And that's where groups like the FDA have done a lot of thinking in terms of what reliability means for medical product development. There's a whole number of guidance documents and frameworks that have come out, primarily more on EHR data, electronic health record data, also claims. But when we get into the multimodal idea, you've got genomics, you've got sensor data with watches. Verily also runs CDC's National Wastewater Surveillance Program. So during the COVID pandemic, you would hear, hey, there's going to be an early wave of COVID that's happening. Well, how did we know? We were testing wastewater. And so that program has come to us at Verily, and that is another data point where if you can start linking together these very diverse and novel sources of data, you can get more insight, not just more insight, but precision insight about your own genomics and kind of what makes up your health stock as an individual. And it's really important, though, that we all have a common understanding of where the data is coming from, its provenance, the accuracy, the completeness, who has had access to it, what has gone into curating it to the point where it is being used for a particular use case. And there needs to be perhaps some more awareness and education around what goes into data curation.
All right, ask one more question, then we'll take some questions from the audience, and you guys can close up with whatever remarks you'd like. But all this talk of data inevitably leads to privacy. So what are some of the best ways, or how should we think about both getting all this data that's needed, but making sure that we're protecting people's privacy? Sylvia, if you'd like to start.
Sure. So all of the data that is paid for, generated by federal funds. So when the grantees are applying for their grants, they, have to say that they will share that data. And really, of course, the thought behind that is, if the government has paid for something, no need for, other people to continually repeat those experiments. If the data's there, let's share it, let's make it available. And so their grantees are required to deposit their data. And one of the places that they can deposit is called the Database of Genotypes and Phenotypes, amongst other places. So we have multiple repositories. And in those repositories, when the data is coming in, there are data use limitations that there's a whole committee that says this is the data that has come in, this is how the data is supposed to be used. And so when someone would like to use that data, they submit an application and they state how they would use the data. And there's a committee that checks and says, hey, this data was consented for example, breast cancer. And so this person would like to do breast cancer research. So yes, they may have access to the data. So those are some of the things that we're doing at the NIH, is making sure that when we are distributing data for reuse, that we are staying true to what the consent was. And also, we want data, of course, right, to be shared, because if we're just holding on to it, we don't accomplish as much. But, we want to make sure that we're doing it appropriately. And some of the things that we're trying to do as researchers are applying is also just encouraging them to look at, all the different areas that their data could be used for, so that when they're submitting those data use limitations, they're not as restrictive. So we're working, on both ends there. But definitely, we are for appropriate data use.
Yeah, +1, I think I'll just reiterate the health data utility model point, where we're still building this out, and this is actually something that we want to get out in the field later this year. And I think that there could be a lot of potential here because there are a lot of state exemplars. States are doing a lot of great work when it comes to data collection and interoperability, but the problem again is that we basically have 50 different healthcare systems if you think about it. So now we're just trying to tackle how do we actually create one unified national healthcare system. So I think I'll just kind of stop with that.
Yeah, the data liquidity is absolutely fundamental to making all of this work. And David, you and I were talking before the event a little bit, reminiscing on past DC experiences and kind of the history that has gone into this. In a prior life, I was at the ONC National Coordinator for Health Information Technology within the Office of the Secretary at HHS. We were the ones developing kind of what an EHR should be doing as functionalities. One of the projects that came to my team was developing rules of the road for nationwide health information exchange. We came out with a advanced notice of proposed rulemaking in 2011-ish. Didn't really go anywhere. And then 2016 happens. That's the 21st Century Cures legislation. For those students, I'm trying to give a little bit of a history here with health policy. These are some really important legislative efforts to be tracking. But the 21st Century Cures initiative also had the same mandate, nationwide health information exchange. And so that is now become what has become TEPFCA, the Trusted Exchange Framework at ONC, which again is allowing for these health systems to come together, participate, share information about a patient, and helps the patient direct to where they want their data to go. There's still a lot of room for progress and improvement. One being HIPAA. And so HIPAA, again, back in the 90s, this was like a Clinton effort when that was passed. It's the main law, baseline law for governing privacy. And it's still kind of used in very varied ways. And it's almost like a defensive posture. So for kind of lawyers or aspiring lawyers in the room, you're always going to be adverse to risk. And when it comes to privacy, sometimes you're, from a health system perspective, saying, well, I'm not sure if I share this data, is that going to put me at risk for something? And how is this going to be interpreted for, a potential HIPAA violation? And so when you don't have a standard way of applying HIPAA or in regulatory perspective and getting into the implementation of data exchange, it starts to get really choppy and really fragmented. And so these are some areas in which we need to continue to find progress and think through how we can have a seamless, unified network.
All right, thanks. One thing you'd say for Washington, whether you like it or not, is no one produces acronyms like this city. So, okay, great. Let's go to some questions. First with your hand up. I think we have a mic going around. Okay, great.
Hi, everyone. So my question, I think it goes towards what Sophie brought up earlier, and I believe that AI is a good thing. I believe the research that you guys have done has shown that. And so my question stems from, how do we put this in the more common community? Because on an academic space or in academic arenas, we see that it's a good thing as far as the research and things like that. But I think when we come from a diaspora, I guess, perspective, sometimes it's hard when everything's a bit foreign. And so giving out all this information, even if you're showing them the data that's showing that there's progression in using AI, there's still that fear that still lingers there, especially since most people it's been ingrained that AI and robots are going to take over and things of that nature. So how do we make it more personal for these communities to feel more open to giving this information so that we can move forward?
So I'd say a big thing is education, but I think the education has to come from people that they trust. So I think definitely we need to form relationships, have advocates who are part of the community who can go out and say, hey, this is what has gone on before, and I understand you because I am part of your community. I understand you, but here is why we need to now work together and give our data, because previously we didn't give our data or we stayed away to protect ourselves. But now, right, in order to protect ourselves and our children, we now need to work together with the community, with the researchers. And also, I think going back to the education is also showing them, right, some of those results like, hey, these are some of the treatments that have been developed for these type of cancers, and this is how certain populations are responding to those cancers. They're more responsive. Other populations are not as responsive. So it's all right in the data, in the information. It's all in education, and trust is a really, really big part of that. So I definitely say advocates are going to be a big key in getting data from populations that are resistant and don't trust. And I think with AI in general, I mean, I think most people have like some hesitation, right? So transparency is going to be a big thing, right? So even at the NCI, we're working really hard now as we're developing governance frameworks and trying to determine, hey, the AI tools that we're using here, what do people know about them, right? Like, how can you interpret what it did? How transparent is it? Like, how did it come to this conclusion? You gave it some information. How did it bring an output? So if people can kind of understand where the answer came from that the AI is giving, they're more likely to start to trust it. So advocacy and transparency, I would say.
Sunita, Adam, do you?
Yeah, well, fantastic question. I'm sorry. Oh, yeah, go ahead. No, okay. No, just fantastic question. That is absolutely a critical thing for us to be thinking through in order for it to systematic use and scalability. The trust is necessary fully, and in addition to that, it's being able to essentially ensure that the value is also coming back to the patient. So historically, the patient has the data, someone perhaps monetizes that data, and then the value doesn't come back to the patient. So does that make sense? No. We need to find value, that feedback loop, back to the patient to show how your data is being used and how that it's actually impacting you as an individual in your care.
I like the idea of getting paid to give my data, but there you go.
I mean, I also just want to loop back to AI tools too, even though your question was more centered around data. I think that right now education is really important, especially, I'm glad that there's so many students in the room today because I think all of you already know how to use these AI tools way better than we do. And I think that's fantastic and that's how it should be. But I think that there's a huge education discrepancy here now too, because I think a lot of you are more comfortable with using these AI tools. You kind of know how to use them. You're being educated with them. But then a lot of people that are older than you, we're kind of like, why am I using this? Like, I don't trust this. I'm not sure. So I also think that's a big part of healthcare and medicine too, because I think a lot of people are going to LLMs now to, ask their medical questions versus going to their doctor because they don't trust their doctor or their care team. So I still think that, trust is really the crux of it all. Of like, if we can't improve trustworthiness and trust in the system, then I think everything else won't be able to advance.
All right, wait, there you go. We'll take your.
Hello, my name is Adriana, and great panel presentation. So you kind of touched on it a little bit at the end of your last response, but just for more clarification on the administrative side and how our healthcare workers are truly adapting to utilizing these AI tools, how are we ensuring that in these lower income communities that these healthcare workers are implementing it to the fullest of their ability? And also, are they wanting to? Is it replacing them? I know that's a big thing that has been brought up when it comes to using artificial intelligence. And then we have all these healthcare workers and the administrative side plays such a big part. So I'm just wondering, are workers worried about the replacement of AI taking their jobs, and maybe is that why they're more hesitant? Or is it more so that they just aren't being educated fully?
Yeah, I think it's both. I think in the beginning there was a lot of fear about displacement. I know that a lot of our clinicians are really nervous about like, well, what's the point of my job if they're using LLMs now? And then they come in with their results saying, well, this is already what ChatGPT told me, just give me my meds or just kind of help me with, whatever else I need. So it's like, well, what's the point of, me being a physician? But I think right now it's kind of turned a little where, and it's kind of what I was talking about. I think that older physicians and nurses and health professionals are a little bit more wary of using these tools because they're going to have a routine down. I've talked to so many clinicians where they're like, I know that I could use an LLM if I'm, for a health system that might have it, but I don't feel comfortable doing that. I want to write my notes by hand. I want to, write my encounters after. I want to be with my patient. But then you have a lot of younger generations that are coming in saying, this AI scribe is going to be huge for me. It's going to cut down my pajama time. I can actually look at my patient for 15 minutes and then I don't have to worry about my notes. And so again, I think right now what's happening and what we're actually really trying to focus on, and we are trying to partner with Google on this, is that we really want to start thinking about health education over this next year to say, okay, we need to actually start thinking about curriculum in all health professional schools now so that we can actually get more acquainted with these LLM tools, but then the faculty needs to as well so they can teach this. Because again, you have a lot of comfort levels right now that we're already seeing, and I think it's only going to get worse if we don't bring everyone onto the same page of this is how you can use these tools, this is how they can help you. Obviously, you can use this within your limits, but for the lower resource clinics and communities, I can speak to a couple of FQHCs where, again, they don't have the resources for this. And some of the med students or some of the residents or faculty, they are getting scribes out of their own pocket because they are like, I have to see 50 patients a day. This would really help me. But they aren't getting it from their clinic or their system yet. So I think that kind of goes to my earlier point where we really need to make sure that everyone has access to these tools so that they can use it. And at the same time, we're educating them. We're making sure that they trust these tools. And then hopefully we would see benefit for all.
Okay, I think we have time for one more question. I know you had your hand up, so.
Good morning. My name is Jahani Strong, and when I think of AI and the medical field, I immediately turn to those with physical disabilities, particularly those who had limbs but then got lost or lost them due to an accident. I'm wondering if you guys have done any research or are currently working on any technological advancements to create limbs for those individuals that also kind of mimic the same movements that we have to make their lifestyle a little bit more easier and back to what it used to be.
Anyone involved in that type of research, or?
No, but I think that's great. And I think we should definitely have more funding in that arena for sure.
Well, it's a great question. You stumped them. There you go. I'll take one more. I think so. Back there. Thank you.
Hi, I'm Kenna. Really appreciate the panel. I would say I think of AI really as a neutral tool. It depends on how it's used. I think there are great applications, as we talked about, in precision medicine and clinical trials. There are also terrifying applications, for example, insurance companies using it for risk assessment and to charge people, basically squeezing them out of their last dollar. I think what frustrates me about the current situation is that it seems it's a lot easier to sort of build for enterprise, B2B, as opposed to build D2C, direct to consumer. And so a part of it obviously is our reimbursement models and just sort of how tangled our systems is and how difficult that becomes. Another part of it might be sort of that building of trust, and also it might be harder to build directly for the consumer. But I'm wondering if you have any thoughts on how do we, what can be done, especially in the political world, to ensure that we're creating and making it easier for high quality direct to consumer care to happen? And how do we address sort of some of the downfalls that AI can have in making care more difficult to receive or more expensive?
Quickly, anyone want to tackle that one?
Sure. Another wonderful question. So yes, and I would say it comes down to a lot of the themes that we've already discussed this morning: the trust, being able to make sure that you have an understanding of kind of your agency as a person with your data. Where is it going? How is it being used? All of those are really important factors for this. But engaging with patients is exactly where Verily thinks we should be going as well. And so again, we've got the consumer app, and ultimately your data coming directly from you is a very high utility source of data. And when you think about bias and you think about confounding, particularly when you have data that's been collected and then you're what we call secondary use of the data, you're using data that's been collected for care and then kind of curating it for another use case, perhaps research, there's biases and confounding that start to creep up into this data set. And that's where there's a lot of in economics unobservable errors that you just can't necessarily track. And that's what makes FDA nervous about the data sets. You could have a practice with a hospital system that has, a tendency for, this kind of care delivery, and then in another health system, a different kind of care delivery. And so this is all going into the fact that what is going into the data and how can we trust the data? If it's coming directly from you as a person, I mean, we can start to minimize and take out some of those biases potentially as well. So having the ability to engage with patients and having the patient being at the center of their care journey is absolutely critical to making what you're saying work.
All right, I think we come to the end here, but if each of you just want to leave, what's one thing you'd want the audience here to leave knowing or you'd like to reemphasize before we end this? I would start with you, Sylvia.
I think one thing I'd like to leave the audience with is just knowing that, like at the National Cancer Institute, one of the focuses that we're shifting into, right, is there's been a lot of funding and into like these new innovations, but we definitely are interested in making sure that there's a workforce that's able to use those innovations, and so are starting to talk about institutional and training grants so that the students who are there can use the AI, but also not just early career, just some of those cancer researchers who've been in the lab, right? They're able, maybe to say, hey, what can AI do for me? A lot of them don't know what questions can be answered, how AI can help them. So we definitely want to make sure that across the board that we have a workforce that's ready to use, AI.
Shameless plug. FIU is pretty good at that.
Wonderful.
Yeah, I mean, plus one to all of that. And I mean, we're here at FIU speaking to all the students. It's really about you all. I think that right now, education and training is really important and making sure that the next generation knows how to fix things. But at the same time, we really need to just tackle trust. We have to tackle data. I mean, we still have a lot of big issues that we've been working on for 30 years. And there's a reason that we're still working on it because we really do need to solve it.
Adam?
I'd say, hey, engage here in DC with Congress to be able to fix things. The baseline law happens not too far away from where you all are sitting right now, and being able to kind of be involved in the process and understand how it works. There's incredible opportunities, particularly when we talk about AI, for students in this room to be thinking about how to engage and how to make problems, how to solve problems and make things better.
Great. All right, well, let's give a round of, sorry. Your last word? My last word, subscribe to Punchbowl News. And if you are engaging with the government and have any scoops, get my email address. No, thanks. So let's give a round of applause here to our great panel.
And on behalf of FIU, I also want to thank our panelists. No pressure, Adam and Verily. All of our panelists have either hired our amazing talent or have our student interns there. But we can take care of that, Adam, right? But since we've been talking about education and training, and I see our friends at AAMC, Erica back joining us, it's an honor to introduce another one of our great colleagues that, as we weave together education and training, but also, like Dr. Azam, very active here in the federal space and working with our friends in Congress. Dean Juan Sandan with our Herbert Wertheim College of Medicine to close us out.
Thank you, panelists. Thank you, Carlos. So the challenge is 90 seconds to summarize a $1 trillion emerging industry and everything we've heard, today. I think what I'll do is, and you guys tell me if I've missed something, but I tried to put into buckets the topics that bubbled up today that I think are worthy of our consideration. There's an entire question around value of the technology, including things like actual cost of it, like electronic health record costs. Someone mentioned a very important electronic health record system. The partner we have is bringing that health system, that electronic health record system, into its 12 hospital space. It's a $500 million investment. That's just 12 hospitals, but America's, thousands and thousands of hospitals. The costs are huge. Evidence and validation, we heard some information coming from our own research team, from Dr. Azam. Early evidence, how do you validate that? How do you scale that so that it could actually turn into something important? We've heard that there's an entire movement around creating databases around many, many children, because you need that many number of patients to be able to make the decision. So evidence and validation before we make big decisions about treatment. Trust, bias, and transparency, another huge bucket that came up over and over and over and is linked to the data infrastructure privacy HIPAA universe. Those are like overlapping. They create tensions to and fro. You can't do one without the other. Interoperability is in the middle of those two extremes, pushing the information back and forth. So I think we have a lot of that. Ultimately, what will manage that is the next bucket, which is policy. Policy, regulations, and ultimately, if a patient's outcome is negative, there will be a lawsuit. Does Google want that lawsuit? That's the deep pocket. Or is it the physician who touched the decision for a millisecond and wasn't exactly sure how the decision was made? Because none of us exactly know how AI decides the outcome. So I think we have a big, giant, floating question mark that's looking at us from the side of every bus that goes by here with malpractice lawyers on it, which I've been seeing quite a few of those. We talked about a workflow issue, which tips right into the education question, and it's great to hear that our colleagues at National Academy of Medicine, AAMC, are thinking about that. We think about that every day as we train pre-medical students, medical students, residents, the workforce. So we've got all of those. I think that puts us, it boils us down into your university partners are good partners, because we're in the middle of the academic health center space. We have patients, we have the trainees, we have hospitals, we have clinics. The cauldron is sort of there to try to answer some of these questions, and the motivation is maybe a little bit more focused on benefit of patient, maybe a little more focused on the benefit of patient than maybe pure economic decisions, business-driven decisions, et cetera. So I think we have something there that we can offer. What I didn't hear today, which is super interesting, is that no one questioned whether AI technologically can answer these questions for us. I think that the cat's out of the bag. We know that AI is going to answer a lot of these questions. It has the computational possibility to help us tremendously. So that's kind of a cool piece, which I did not hear. So I think the outcome is going to depend less on our technical capability and more on the evidence, governance, workforce readiness, and sustained trust in the areas where policy, academics, and health systems really need to move in concert. Did I miss anything?
Pretty good.
That's why you're the boss.
Thank you all very much. Thank you to our panelists. Yeah, cheers.
Cool. We're going to take a quick group. Thank you all very much. We'll take a quick group photo of the panel.